So good morning, good afternoon and good evening all. Once again, a very warm welcome on behalf of MYT. We are very much looking forward to supporting you with today's Test and Learn series conversation, Costs and Efficiencies related to integrated campaigns, methods and findings from Sierra Leone and Nigeria. And I'm now delighted to hand over to Leah to welcome you to the conversation. Thank you.
Good evening, good afternoon, and good morning. It is my pleasure to welcome you to the fourth Test and Learn session hosted by the Health Campaign Effectiveness Coalition, the first ever partnership for cross-campaign collaboration. My name is Leah Denise Wyatt. I am the Senior Associate Health Campaign Effectiveness Coalition Director and host of today's session. Please take a moment to share which country you are joining from in the chat. And I'm just going to watch the chat here. So please share which country you are joining from. Thank you. The Test and Learn series fosters and facilitates learning, collaboration, and systems change across and between health campaigns. We have a narrow focus on levers within health campaigns that improve coverage, equity, cost effectiveness, and health impact, all common areas of interest among health campaign actors. Now, I would like for us to get acquainted for just a moment. Please indicate in this poll which health campaign phase you are currently and primarily engaged in. You can choose planning, implementation, or follow-up now. I'll just give you a moment to fill that in. Okay, we can go ahead and show those results. Okay, so about half of us that responded are in the planning phase. Okay, so we are logging into this conversation from at least 20 countries, and we represent the full spectrum of organizations involved in campaign delivery, from ministries of health to academic institutions, in addition to philanthropic, non-governmental, and multilateral organizations. Representatives of the same bodies expressed an interest in exploring effective campaign planning in the first annual coalition meeting in October of 2020. Those coalition members saw an opportunity to understand factors that enable and hinder campaign effectiveness across contexts. Today, we join in conversation with Laura Boonstoppel of Thinkwell, who will share with us preliminary findings from a study that begins to unveil the costs of conducting integrated campaigns. Today, Laura will share preliminary findings from studies in Sierra Leone and Nigeria. Our moderator is Dr. Deborah A. McFarland. She is an associate professor of health policy and management at the Rollins School of Public Health at Emory University. Dr. McFarland has been involved in health policy and health financing issues for the past 35 years, with a particular interest in the interface of disease control programs in health systems and the ethics and economics of resource allocations for public health priorities. Since 2000, Dr. McFarland has focused her service, practice, and applied research on neglected tropical diseases. She is a member of the World Health Organization Neglected Tropical Diseases Scientific and Technical Advisory Groups, the WHO Technical Consultative Committee for the Africa Program on Onchocerciasis Control, and the WHO and UNICEF Tropical Disease Research Special Advisory Committee, and the MECDAZAN Expert Committee for Neglected Tropical Diseases. Dr. McFarland is also a member of the Health Campaign Effectiveness Coalition Scientific and Technical Advisory Committee. We are honored to have you, Dr. McFarland. Dr. McFarland and Laura will take comments and questions from the study and discuss how they translate into recommendations and actions. I now turn the floor over to you, our moderator, Dr. McFarland.
Thanks very much, Leah. Welcome to everyone. It's good to not see everyone, but it's good to know you're out there. We are pleased, as Laura has said, to have, as Leah has said, to have Laura Boonstoppel with us from Thinkwell. She is currently the project director for the economics of Last Mile Delivery Hub, and she's led several other immunization costing projects with allocative efficiency analyses, health labor market efficiencies and analyses, and a number of other products. So Laura is a legitimate expert on this topic of cost and cost efficiencies of integrated campaigns, with a particular focus on integration of campaigns with immunization strategies. So I'm going to turn it over straight away to you, Laura. I think the issue of cost is one that all program managers can identify with. They're often asked by their policy managers, by the people in the Ministry of Health, the Ministry of Finance. Well, can you tell us what it cost? And whatever the it is. So today we're going to focus on how do we answer that? And I turn it over right now to you, Laura, to start us straight away on your presentation. Thank you very, very much.
Thank you for the kind introduction, Deb, and thanks to everyone else for joining today's webinar. So as Deb just explained, my name is Laura Boonstoppel, and I'll be presenting some of our work around the costs of integrated campaigns. And I also just wanted to briefly recognize everyone else that has contributed to the studies, who are all listed on the slide here.
Oh, dear.
So I'll first explain the context of this work on integrated campaigns, as it's part of a larger project that we've implemented. And then I'll discuss the two integrated campaigns that we've studied, when and how they were implemented and so on. And then I'll get to the interesting part where I'll present some of the findings that we can then discuss together. So starting off with a bit of background. So between 2017 and 2019, colleagues of mine have conducted a systematic review of all evidence available in academic journals, but also in the gray literature and other types of publications on the cost of delivering immunization in low and middle income countries. And because there was a lot of evidence out there, but nobody had yet pulled that together in a comprehensive manner, this made it hard for decision makers to access and use it. And so they extracted the key data from those publications, standardized it, and then pulled it together into this large database that we call the Immunization Delivery Cost Catalog, which anyone can access on the link on the slides here, immunizationeconomics.org. And so what came out of this review is that although the database contains more than 660 unit costs on vaccine delivery in total, only 33 of those, and if you're looking at the chart, that's the 5% here, covered campaigns and outbreak responses. And so when looking at the estimates that were available, we noticed that the evidence varied widely, but also that they used different methods. And so it wasn't necessarily clear whether the costs of conducting these campaigns were indeed so very different, or whether the outcomes of the studies were just different because of the various methods that had been used. And at the same time, countries and donors invest a lot in these campaigns. And so they're really this one-off opportunity to make a big impact. And so it's important that we get it right. And so we need to know what they cost so that they can be properly planned for. And so the aim of our work was to improve the standardization of campaign costing methods so that the evidence coming out of campaign costing studies is more comparable and thereby more useful to practitioners at country level, but also at global level. And so our methodological guidance on how to cost immunization campaigns is largely built off of some existing guidance on costing methods, consultations with costing experts, and we conducted 3 immunization campaign costing studies as part of this work. And we followed an iterative process to test various methods in the field and to basically improve on these methods with each of these studies. So the first study took place in India around the measles rubella catch-up campaign that took place there. The next one costed an integrated measles rubella campaign in Sierra Leone. And the last one focused on yellow fever campaigns in Nigeria, which were integrated with meningitis A. And then today's webinar will focus on the latter two of those studies, the ones that focused on integrated campaigns. And I should probably also mention that the methodological guidance is nearly final and will become available in the next few weeks. So before I dive into these two integrated campaigns, let me just pause here for a second in case there are any clarifying questions on this part.
Thank you, Laura. Please put your questions in the chat box or in the Q&A as you think of them and as Laura proceeds. Okay, Laura, without any questions, let's go ahead and move on to the next section. Thanks very much.
Yeah. So now let's dive into the two studies on integrated campaigns. So the objective of both of these studies was to estimate the delivery cost, which is sometimes also referred to as operational costs of each of these campaigns. And so we estimated both the financial cost as well as the economic cost. And so for those not familiar with those terms, financial costs are financial outlays specific to the campaign. And so, for example, that includes per diems or fuel cost or the cost of organizing workshops, things like that. And economic costs reflect the full opportunity cost of a campaign. So in addition to the financial outlays specific to a campaign, they also include the value of existing resources, like the cost of a health worker's time and the value of, for example, cold chain equipment or vehicles that are being used for the campaign. And so the perspective of both of the studies was that of the government entity responsible for the campaign's implementation at all levels, so including costs incurred at the facility level, but also all the administrative levels above that, all the way up to the national or federal level. And we also included the costs incurred by implementing partners like WHO or UNICEF and other NGOs that participated. And we collected the data retrospectively, which means that we collected it after the campaign had already been implemented and completed in both of these countries. And we estimated the cost by resource type, so that includes categories like labor and transport, as well as by campaign activity. So examples of that are service delivery, social mobilization, training, record keeping, and supervision. And as study outputs, we estimated the cost per dose delivered using weighted volume averages, and we included sampling weights to take into account each site's probability of being part of our sample. So here's an overview of both of the campaigns. So for both of these, the integration part was mostly something that was added on after initial campaign had already been planned. So that initial campaign in the case of Sierra Leone was a measles rubella catch-up campaign that targeted all children under the age of 15, which was followed then by a switch from measles to MR routine. And in Nigeria, these were yellow fever campaigns that targeted everyone under the age of 45 as part of its larger yellow fever elimination strategy. And so co-delivery interventions that were added to that in Sierra Leone included oral polio vaccine administration nationwide and nutrition supplements in half of the country. And in Nigeria, Mene was co-delivered in one of the states included in our sample. And in both countries, this was the first time that two vaccines were delivered together through a campaign. And in both countries, the campaigns were fully integrated, meaning that everything from management, training, distribution, all the way down to service delivery strategies were integrated. And the delivery strategies that were used included temporary fixed sites in both cases. Sierra Leone also relied heavily on school-based delivery for MR, and also used mobile teams to go around in the communities. And both countries also offered the vaccines at the facilities themselves during the campaign. And the Sierra Leone campaign took place in June 2019 and took 7 days and was implemented nationwide at the same time. Whereas in Nigeria, each state held a 10-day campaign, and these were phased over 2019 and 2020 for the campaigns conducted as part of this phase of the country's yellow fever elimination strategy. So that's the campaigns in general, then our specific sample for the study. So in Sierra Leone, we considered the entire country as part of our sampling frame, while in Nigeria, we looked at just the states that were part of phase 3 of the country's yellow fever elimination strategy that I just mentioned, which includes 4 states in total. And out of that, we selected 3 states to cover the north, middle, and south of the country. And below that, we randomly selected local government areas and wards of different sizes. And in Sierra Leone, the EPI manager suggested us to include 2 districts with geographic challenges. And in addition to that, we selected 4 districts randomly to end up with a sample that included 3 districts that delivered all interventions during the campaign. So that's measles, rubella, oral polio vaccine, vitamin A tablets, and deworming tablets, and 3 districts that delivered only the vaccine, so only measles, rubella, and oral polio vaccine. And below that, we used stratified random sampling to arrive at a mix of urban and rural facilities and public and non-public facilities. So our final sample included 30 facilities in Sierra Leone and 78 in Nigeria. And we collected the data from October 2019 to February 2020 in Sierra Leone, and from October 2020 to June of this year in Nigeria. So that's an overview of the specific campaigns and how we conducted the study. And I'll pause again for questions on this part before we move over to the study findings.
Thank you, Laura. Yes, there are a couple of questions in the chat box, so let me turn to them just to recognize that they are there. And perhaps you'll be addressing these later, but if not, I want to highlight the one from Fikrob. Were these campaigns undertaken during COVID? And then a small question, what's the key difference between mobile and fixed sites? So if you could respond to that.
Great questions. So the campaigns in Sierra Leone were undertaken pre-COVID. So all of that took place in 2019. In Nigeria, 2 of the states that were included in our sample conducted campaigns before COVID, and one of them started just before the COVID outbreak and then completed the latter half during COVID. And that's a state on which we're not presenting results today, actually, because we're still analyzing those, because it also is the state where the campaign was completed last. So all of the data that we're looking at today all concerns pre-COVID campaigns. Then the question on the difference between fixed sites and mobile teams, right?
Yeah. Yes, that's right.
Okay, so fixed sites can either be facilities, and then usually we distinguish between facilities and temporary fixed sites, which can be a site that's set up in a community center or in a church, or it can just be in an open space like next to a market or something like that. So it just means that the team is in a fixed place while they're delivering the administration, and the people that want to get their children vaccinated come to them, whereas mobile teams go around in the community actively trying to recruit people to get immunized.
Very good. Thanks very much. There are a couple of other questions I wanted. There's one from Damien that is specifically related to COVID and the insecurity and how you deal with the issues of insecurity, particularly in Katsina in Nigeria, but perhaps it's a more general question of, are there issues around data collection in areas where there's COVID-19 and insecurity at the same time?
Yeah, so that's a good point. And indeed, some of the data was collected during the COVID pandemic. And so we did take that into consideration. In Nigeria, we had a long pause during our data collection because of this, and only went ahead when the states in which we were collecting data were considered safe at the time, with the appropriate permissions, of course. And of course, in some of the Nigerian states, there are other security concerns as well beyond COVID that we had to take into account. And so even though we envisioned our sample to be 100% random, in the end, in some of the states, we had to replace some of the local government areas with others to take the safety of our data collectors into consideration.
Okay, great. Perhaps one more question that is in the chat box. We'll come back to some of these if we have time at the end, but we'll continue on with just one more question. Unit costs, as we know, vary widely. Did you find any evidence that cost varies along the different vaccines being delivered? And if not, are there other factors that drive cost differences per unit?
Yeah, so this would be a question for the colleagues of mine that have conducted this systematic review that I mentioned at the beginning of the presentation. And they have done a lot of analysis to try to pinpoint estimates that are vaccine specific, and the evidence wasn't narrow enough to really say this vaccine is more expensive to deliver than others. But of course, things that they found were that different delivery strategies that are used play a role. So if a target population is particularly in a remote area, this drives up the cost. If they're hard to reach populations, anything related to outbreak responses, so difficult settings usually drives up the cost, but it's not necessarily antigen specific. But invite you to look at the evidence in the immunization delivery cost catalog online as well to look at some of these differences.
Great. If we could put that link in the chat, that would be helpful as well. Laura, I don't expect you to do that, but perhaps some folks from HCA and the task force can do that. All right. I think there are a couple of other methodological questions and I want to get to those. How did you deal with equipment costs that span more than 2 years or more, that have a lifetime of more than 2 years? I guess it's a broader question of how you deal with capital costs and do you include those in your estimates?
Yeah, so we did include capital costs in our estimates, and we considered capital cost anything with a life beyond 1 year. So that includes the 2-year example here. So we annualized those and discounted those. So we used useful life data from the countries themselves, and replacement prices also collected mostly at the countries themselves. And wherever we had data gaps, we used WHO choice data to complement.
Okay, that's great. Well, there are a number of other questions. And one other one that perhaps we can get into at the end, because it's one that I have as well, and that how were the Ministry of Health staff or other staff engaged in the design, implementation, and analysis of the cost studies? So it's a question about who's doing this, who's doing the data collection and helping with the analyses. So thanks, David Gittleman, for asking the question.
Yeah. So in Sierra Leone, we worked with staff that were mostly statistics staff. And so we worked together with the Ministry of Health when designing the study. So the EPI manager chose the districts that we were working in. They agreed to the design, they agreed to the co-delivery part, and the different outputs that we were focusing on, and the questions that we were going to ask their staff. In Nigeria, we worked with the MPHCDA, as well as with all the implementing partners when we designed the study. And the actual data collection and analysis is conducted by the University of Nigeria.
I see. Okay. Well, I know we're running on. Why don't we move on to the next section, and we'll come back to some of the specific questions about issues in sampling design, et cetera, in Nigeria, and perhaps specific questions about Sierra Leone after Laura has presented the results of the studies that she and her colleagues have been working on. Thanks.
Yeah, okay, so then over to the results and findings of our studies on integrated campaigns. So on this slide, we see the financial delivery cost of the campaign in Sierra Leone. And in the graph, we see the delivery cost. So that excludes the vaccines and the supplements themselves. So it's really just the cost of delivering those interventions. And we show the delivery cost per dose delivered. And we see that nationwide, this came down to 31 cents per dose of any intervention delivered. And when comparing areas that delivered all 4 interventions, so that's MR, OPV vaccines, as well as the nutrition interventions, there the cost per dose was lower, so 28 cents. And in districts where only vaccines were delivered, the cost per dose delivered was higher, 38 cents. And this makes sense when we think about the fact that many campaign activities were shared across the campaign, and many big financial expenditures for the campaign don't necessarily increase with the number of doses delivered. So for example, health workers receive the same per diem during a campaign day in Sierra Leone, regardless of how many children they manage to reach with how many doses of which vaccine or nutrition supplement. And so if we look at the same data again, but using the same denominator, so we can better compare the financial cost differences across the 2 regions. So here we show the cost per vaccine dose delivered in both areas, which shows that then the cost per dose is almost similar in both areas. So this implies that financial cost efficiencies can indeed be achieved through the form of integration that took place in Sierra Leone. Then if we now look at the same kind of data for Nigeria, here we actually found something different. So in this graph, we see the delivery cost per vaccine dose delivered. And in Katsina State, the bar on the left, only yellow fever vaccine was administered during the campaign, while in Anambra State, which is the bar on the right, yellow fever and meningitis A vaccines were delivered during the campaign. And here, the delivery cost per dose of any vaccine is actually higher in Anambra, even though they delivered more interventions. And so if we run the same comparison where we look at a common denominator across the 2 states, which is the cost per yellow fever dose only, then the difference becomes even greater. And so why is this? Why aren't we seeing these efficiencies that we just saw in Sierra Leone? So when looking at the cost more closely, what we saw is that Anambra actually spent more on per diems per dose delivered than Katsina did. And so these are really just our preliminary results. We really just produced them. So we'll still have to do a bit more digging to better understand why the co-delivery state paid higher per diems and what those were for exactly. But what we expect, for example, is that this may be linked to the fact that both meningitis A and yellow fever receive Gavi operational cost support for campaigns, while in Sierra Leone, measles rubella vaccine received Gavi support, and the other interventions that were co-delivered only brought small amounts of additional funding to the campaign from the other programs. So what we see is that the way that the campaign is run and financed is likely a big driver of the financial cost differences that we can see for a campaign. So then we've talked about the financial cost. So that's financial expenditures that were incurred just for the purpose of the campaign. So now we're going to have a look at the economic cost of the campaign. So as I mentioned before, economic costs also reflect the opportunity cost of the campaign, and this includes the value of the use of existing resources. And in both campaigns, the largest cost driver of the economic cost is the value of labor. So that's the value of the time spent by regular health workers on the campaign, which is time that they could then not spend on delivering other health interventions, and an estimation of the value of time of volunteers that participated in the campaign. So on the left, you see the economic cost per dose of any vaccine delivered in Nigeria. And on the right, the comparison in Sierra Leone per dose of any intervention delivered. So what we see is the same difference for the financial costs, that in the co-delivery state in Nigeria, the economic delivery cost per dose is higher, while in Sierra Leone, the economic cost per dose in the co-delivery districts was lower compared with other districts that delivered fewer interventions. And we can also look at these data again to use a common denominator to better compare the 2 regions in each of the countries. And here we see that in Nigeria, as well as in Sierra Leone, that in the area that co-delivered more interventions, the economic costs for those delivered are higher. So what this implies is that additional labor was required to deliver these additional interventions. So let's summarize the points made on the previous slides. So first, we saw that fully integrated delivery models like those used in Sierra Leone and Nigeria can result in financial cost efficiencies, which is what we saw in Sierra Leone, but that this isn't necessarily always the case, which is what we saw in Nigeria. The second thing we notice is that even when financial cost efficiencies are there, then co-delivery still requires additional use of existing resources. And so that's mainly health worker and volunteer time to make those integrated campaigns happen. And so we should be aware of this when we are planning integrated campaigns and recognize that these resources are not infinite and that this does pose a burden on the system. And then of course, the next question would be, even if we do achieve cost efficiencies, did we compromise on quality by integrating these campaigns? And this is actually a really challenging question to answer because integration does not happen randomly. So in Sierra Leone, the districts that co-delivered nutrition interventions were selected especially because they actually had lower routine coverage for these interventions. And so they may also achieve lower campaign coverage due to these same challenges as well. While in Nigeria, the state where Mane was integrated with yellow fever was actually known to be more of a high capacity state, a good performer. And so they thought that it made for a good candidate for integration. And so all of these factors will drive campaign coverage and we cannot view them separately. So drawing conclusions on whether any kind of equity efficiency trade-off happened is really hard because we don't have a good counterfactual or any kind of before or after comparison that you would have in a routine program because campaigns are conducted as a one-off. And so, and in addition, the integration is never randomly assigned. So with that, I've come to the end of what I wanted to say today, and I'll hand it back over to Deb for her reflections and looking forward to everyone else's comments and questions on this work. Thank you.
Thank you so much, Laura. We have a number of questions and I have some as well, but I'll turn to the audience first. I'm looking in the Q&A and let me just ask some ones that perhaps are more methodologically specific and then ones that are more policy related. One question coming from Asma Ali, were environmental safety or waste management issues included in the costs?
Yeah, so waste management costs were included. So that can be the fuel cost of incinerators, but also the capital cost of incinerators, safety boxes, everything like that.
Okay, I see that Sarah Geldrith would like to answer this question live. I'm not sure. Oh, okay, I think I've already done that. Sorry. All right, so let me move on to some other questions from Liban Mohammed. Effective health coalitions would be better to expand the effective health campaign coalition in Eastern Africa, especially Somalia, for example, where we see a lot of difficulties when it comes to getting polio eradication campaigns in Somalia, malaria, and other infectious diseases. So do you have any other plans that you can make research and advocacy available to implement these huge projects, particularly in places like Somalia? So that's from Liban, from Somalia so he has a specific questions about that. These huge campaigns, polio eradication campaigns, malaria, etc.
Yeah, so I'm not sure if I got the question.
Yeah, I'm perhaps if Liban can come on, if that's possible, perhaps he can make that question more specific. But while he is, let me move on to a question from Patrick at the task force. And it's one that I have as well. How do you account for opportunity costs? In particular, I'm thinking about how did you value volunteer costs and volunteer time? It's an issue that we often come up with in whether it's NTDs, immunization, any campaign, and all of our volunteers are often used in multiple campaign strategies. How did you value that cost? And then Patrick has other questions about opportunity costs. For example, a co-delivered nutrition and vaccine campaign may and probably will cost more than a single vaccination campaign, but perhaps the nutrition campaign might not happen at all, absent the opportunity for co-delivery. So thanks for thinking about that.
So the way we value health worker time is we collect salary scales from the ministry, and we allocate a portion of health workers' monthly salary based on time spent on the campaign. So if it's 10 days times 8 hours, we take that share out of their monthly salary and allocate it to the campaign, assuming that they didn't have time to deliver other health services during that time. For volunteers, quantifying their time in terms of monetary value is more challenging. So we try to distinguish between those that are maybe they've had some level of training, but they don't have an official job at the facility, but we can kind of equivalate them to existing cadres, and those that really are just there to help out in social mobilization activities or just carrying stuff, offloading cold chain materials. And those we value at what is the common day laborers rate in that area that they were active in.
Okay, great, thank you. Liban, we've asked you if you'd be willing to expand on your question. So I think Debbie, the MYT folks are going
to... no problem, Deb. Let me just, I sent Liban a little message as well. So let me just allow you to talk, Liban. Can we just make sure that you pop your microphone on?
Okay, I can hear you now. I can talk.
We can hear go you. Ahead, Liban.
Thank you.
Thank you, Deborah and Laura, and good afternoon, good morning, everyone. And I'm in Somalia. My name is Liban Aden from within a relief organization, WARO. I'm very happy to be part of this meeting, and I'm very excited, and we have collected more and research and more information. So my question is, how does the health campaign and effective health campaign coalition can make a change here in Eastern Africa, especially in Somalia, where we see that you have a lot of health campaign issues related to the program? That's my question.
So I think this is more a question for Chris or Eva, perhaps, to answer, because our work is completed. We've done costing studies in the countries that we've collected costs in as part of the development of our methodological guidance. And so our project is completed, but I'm not sure if other health campaign effectiveness research streams have research projects ongoing in Somalia that could help campaign effectiveness there.
Good.
Oh, thank you, Laura. I was just going to...
I really appreciate it. If I specify my previous question, I meant that you have a lot of campaigns here in the domain or the platform. As we see, you always send and a lot of newsletters, a lot of information is related to the health campaign, but I don't see you have entrepreneurs in Somalia. So that's why my question is based.
Thank you. Deb, I was just going to say quickly, if you're happy that Eva's willing to answer that question, Laura, I know you passed that back. And also, Chris has also confirmed they'd be very happy to talk to you about it in more detail after the call as well, Liban. So let me just see if I can get Eva to pop her microphone on as well. Give me a second. Okay, I'm just going to put you to a panelist, Eva. It'll be 2 seconds.
Okay, thank you,
Thank you, Liban. We'll just see if we can get Eva to answer.
Okay, perhaps while that's happening, just a specific question. Laura, were there any of the results that you found, were any of the differences statistically significant and, quote, meaningfully different? It's a good question. Be curious that
It's
you
a really important one, and we push for reporting on statistical differences because a lot of costing studies don't. So in Sierra Leone, the difference in economic costs between the two regions, so when we talked about the additional labor cost that was incurred in the regions that co-delivered, we did not find this to be statistically significant, but I also have to note that our sample size was really small, only 30 observations. So it's really difficult to then get statistically significant results out of that. For Nigeria, we haven't done this yet. So we really just have the results of these two states. We have them as of yesterday. And so we still have to do this, but our sample there is much larger. And so we hope that we can then have more statistically significant differences between groups there.
Thanks. Laura, I'm just coming in as we just lost Dr. McFarland, but that's okay. I think we can help guide this conversation by way of the Q&A, but I also invite Dr. Bazant to answer the question about Somali participation in the coalition, which is welcome.
Oh, and hello, good afternoon and good evening, good morning to everyone. I'm Eva Bazant, Senior Associate Director for Implementation Research. And we just want to thank the gentleman from Somalia and from other countries for raising issues that need to be looked at, need to be studied in various countries. We know there are countries that do conduct quite a bit of campaigns, Somalia, Nigeria, many other countries. So we are in the business of really understanding what are the needs, what are the gaps, and raising that to the community of organizations that are participating in financing or carrying out or conducting research on campaigns. Our own resources are somewhat limited as we go into the, we're in the second of the third year of our Health Campaign Effectiveness Coalition program, but we will be having a coalition, an annual meeting in October that I'm sure Leah will say more about. So we're trying to understand the needs, and certainly we'd like to understand better the needs in Somalia. And if we can't right away, fund something or support something to elevate the voices and elevate the needs. So we do encourage everyone to be in touch with us and visit our website. And we'd like to address that as we go into our annual coalition meeting. Leah, I don't know if you want to add anything before we return to Laura.
No, I think that's great, and it is true. You can go to campaigneffectiveness.org, and there in the event section, you can find information on how to put the annual coalition meeting on your calendar, so you can hold that date, October 19th and 20th. Thank you, Dr. Bazant. So there's a question that's been promoted, elevated, voted up in the Q&A chat here, which is how can country programs plan campaigns with a prospective costing study of financial and economical costs? How might a prospective study be different than a retrospective one?
Yeah, that's a great question. We had actually intended some of our work to be prospective originally, but then with all of the shifting dates, it's difficult to get it right for a campaign to really be there at the same time as the campaign without disrupting anyone and collecting costs. So that's a challenge. So I don't think from the literature reviews that have been conducted for our immunization delivery cost catalog, for example, that any campaign has ever been costed prospectively, so simultaneous with the campaign. It hasn't happened because it's a challenge and people are afraid of getting in the way. But ways that this could be done, for example, ahead of the campaign is by asking health workers how much time they think they're going to spend on certain activities, which is of course then always going to be biased. Their interpretation of what happened in a retrospective study will also be biased in other ways. And I think the value of prospective costing will probably improve with the frequency with which these campaigns are conducted. So like in the case of Nigeria, they conduct so many campaigns that they probably have a much better estimate than other countries that are less familiar with campaigns.
Mm-hmm. Okay. All right. And I want to just thank the participants for voting on the questions in the Q&A chat. Laura, even if a country does not see financial cost efficiencies when co-delivering several interventions, the benefits for the populations might be a good aspect to analyze. Do you think the benefits can be analyzed in terms of diseases averted and costs avoided for families and health services?
Yeah, that's a really great question. And indeed, our costing studies did not include the cost incurred by those getting their vaccines at the sites. And indeed, they could very well be minimalized by the fact that interventions are co-delivered at the time. And indeed, this is not included in our study and would be a really interesting angle to look at.
Yes. So we have a question from Desika Romance, and that question came in French. You have to forgive me. That is not my language that I speak. And I think you can see the question. Could you please go ahead and answer that one?
The question being, how do you disaggregate the cost by inputs, knowing that
steps in the campaign that were integrated? And so this is indeed a challenge. So we have looked at allocating costs to different interventions to then arrive at estimates for that intervention. But the interpretation of this is hard because they're very much driven by your allocation rules, right? So a common way to allocate costs in these kind of costing studies is by allocating costs based on volume. So we would, for example, say that because measles rubella vaccines were the main intervention in Sierra Leone, therefore we allocate most of the social mobilization costs to measles rubella. But is this really a fair assumption to make or not? And in the end, the estimate that you would arrive at for a cost per dose for vitamin A as a standalone, for example, doesn't tell you what it would cost to implement a vitamin A campaign as a standalone activity. So I think the best way to interpret these results is really as the cost of this intervention as part of a larger campaign, and not take these results out of the context.
Mm-hmm. I want to just thank Dr. McFarland for being able to jump back on. She does this moderator job much better than I do. And thank you for everyone for your patience there. I'm going to hand the microphone back over to you, Dr. McFarland, to continue the conversation. And we'll just dive into those questions as I was.
Great. Thank you, Leah, for taking over. My computer went wacko, so I'm not sure how one translates that into French, Spanish, Arabic, or anything else, but I think wacko is probably a word that we all understand when it comes to computers. Laura, and I'm not sure that this was asked while I was off, but as we come to the end of this session, it would be helpful to know how you are disseminating these results and what the response has been from the policymakers in both Sierra Leone, Nigeria, and even previously of your work in India. It's often difficult to communicate this information in a way that fits on a bumper sticker and that makes sense to policymakers as they are engaged in trying to understand and ferret out the cost of the various interventions and the various disease entities that they're dealing with, as well as other health systems questions in general. So given that as background, could you just give us a sense of what's going to happen to these results? What's the so what question to policymakers and program managers as they move forward? Thanks.
Yeah, thanks. That's an excellent point. So to what we've done in terms of dissemination so far, on the integrated campaign studies, very little, because we've really just completed this work. So this is yet to happen. But on India, for example, we've managed to discuss how the cost estimates in the different states there for measles rubella for the campaign related to their financial norms. So their financial norms are really based on a per child basis. And what our cost estimates showed is that costs differ a lot per region, depending on geographic challenges or whether there are vulnerable populations. Transport costs are, of course, highly variable. Social mobilization efforts had to be differentiated. And so the cost estimates that we produce really help them to make aware that maybe more differentiated ways of budgeting for these kind of efforts would be valuable. And so we're hoping to tailor the conversation in each of these countries to whatever the questions are that are present there.
Okay, that's a good response. I'd still like to pursue that further, but I don't think we have any time. There is a question from Eva, and I don't see it. So perhaps either Leah or one of our other moderators can read off that question, or Eva, if you can make that question audible to the group, that would be helpful. Thanks, Eva.
Sure. I just put it in the chat. I know it's hard to monitor all these screens. So Laura, we really look forward to seeing the costing methodological guidance that Thinkwell will be sharing in the near future. I know you mentioned it's in the final stages. What can we expect to find in the costing methodological guidance, and how will it help country programs answer important questions they may have about their campaigns?
Yeah, so I call it the methodological guidance, but it's actually a set of products. So we have a document that really just describes methods like sampling or how to calculate volume weighted average while taking into consideration your sampling design and all of those kind of factors, and the resource types and cost activities that we recommend you to use so that studies are standardized across and can be compared. Then we're producing a separate document that describes data collection challenges. So exactly who to engage, at what time, training. We're providing templates for questionnaires as well. So more the practical kind of advice. And then for those more familiar with costing, we'll have a document that really just only briefly highlights how campaign costing, for example, differs from routine immunization program costs.
Yeah. That's great. I know we have a question. The protocol, you've just mentioned that it will be available. Do you have any sense of when that will be widely available to both the participants on this webinar as well as a broader audience? Everyone's anxious to.
A couple of weeks, really.
A few weeks.
Yes.
Okay, so everyone hold your breath. And the protocol, the methodology will be available soon. Laura, thank you so much for sharing with us today. Thanks to everyone who's participated. Thank you to those who have asked questions. I know there are a lot more. We could spend the morning on this. It's very helpful. I know that costing is not something that everyone has great facility with, and everyone has great expertise with. So Laura, thank you for bringing your health economics expertise to this vitally important question. As more and more campaigns are integrated, or as more and more campaigns are anticipated. So thank you so much. Thank you to the task force for setting this up, and we will follow up. If there are any follow-up questions, I think that the organizers of the seminar have the next steps about how to move forward. So thanks very much. And apologies again for my laptop going wacko.
No needed. That was out of our control, unfortunately. But thank you, Dr. McFarland, for moderating and being willing and able to spend time with us this morning. And also to you, Laura Boonstoppel, for sharing this most important, relevant, and timely study with us. I will be sure that the task force and the Health Campaign Effectiveness Campaign or Coalition is in partnership with Thinkwell to disseminate not only the results of the finding, but also the methodological guidance referenced earlier in this call. You can expect to receive the recording from this call and related resources in an email following this event. And I have just a couple questions, and this may be even obvious, but participants, did this test and learn session provide you with new knowledge today? I do have a poll, and I really would am interested to know if this is new knowledge for you or not. Okay, great. Wow, 100% excellent. And are you interested in improving cost efficiencies through integrated campaigns? So this is about your interest in improving cost efficiencies. Okay. Wow, great. Okay, so we'll be sure to have targeted information on this related item for those of you who are on this call today and by way of our campaigneffectiveness.org website. So look for the email that comes out following this call for sure. We will have an opportunity to revisit the implications of the study also in the annual coalition meeting October 19th and 20th of this year that we spoke about earlier. In that meeting, we'll identify opportunities to build on what we've learned over the past year and develop practical solutions to the challenges that are common across campaigns within the subject matter. I would like to invite you to also hold this time on September 1st to dive into lessons from collaborative campaign planning studies funded by the Health Campaign Effectiveness Coalition, from the Clinton Health Access Initiative and Ebola Health International, both in Nigeria. In that call, we will learn from our colleagues about promising practices in collaborative planning of health campaign integration. We will also learn about how those promising practices from immunization and malaria campaigns may apply to neglected tropical diseases and vitamin A campaigns. So that's this time, September 1st. You can go to campaigneffectiveness.org to hold that event on your calendar, and also you will receive the registration link in your email soon. Until next time, you are encouraged to stay safe, wear your mask, and wash your hands. And I thank you for your participation and for showing up today. Thank you.